I think probably one of the most pressing questions really has to do with now that we use chemo and immunotherapy in the neoadjuvant triple-negative breast cancer setting, and that a very similar regimen is approved in the metastatic breast cancer setting for triple-negative, is what are our other therapy options? So KEYNOTE-522 is used in the early breast cancer setting, and again, that's pembrolizumab plus 4 chemotherapy agents. If patients were to have a metastatic recurrence, we would use pembrolizumab along with chemotherapy, with several of those agents being similar or identical to the agents that were used in the initial neoadjuvant chemo. I think it's really important that as the needle has moved in both the neoadjuvant and metastatic setting, we're now left asking ourselves in the metastatic setting, should we really retreat patients with a similar regimen if they've had a recent recurrence? And so I think that's a huge need. There are several clinical trials right now that are going on in that setting, and so I'm hopeful that in the next few years we'll have better answers to that question. But currently many oncologists are left, weighing kind of the pros and cons of re-challenging patients with chemotherapies that maybe they saw not too long ago. I think the other question that really is an unmet need in breast cancer is, as our patients, even in the metastatic setting, tend to do better, we're still at a loss for what to do or how best to treat our patients that have brain metastases or leptomeningeal disease. And this is unfortunate because many patients that have brain metastases or leptomeningeal disease are excluded from many of the clinical trials that lead to these advances. And so I think that is a huge unmet need and something that we in oncology really need to pay attention to and be sure that we're including these patients with this very high need for therapy options in our clinical trials and in the real world data sets as well, of trying to get a sense of, do these newer agents work in this patient population? Because as our patients live longer, the risk of developing brain metastasis just increases with time.